Hello everyone, my name is Lauren Boylan and my EBP presentation is called Sweet Dreams Are Made of These, Reducing Patient Perceptions of Noise to Improve Satisfaction Scores. The problem highlighted throughout this presentation is regarding noise levels of acute care inpatient settings that patients perceive throughout their stay, which can contribute to poor quality sleep, a lack of sleep, the requirement of providers having to prescribe some narcotic and controlled medications such as Ambien to promote sleep, and overall decreased or poor ratings on Press Ganey or HCAHPS surveys throughout the healthcare system. Hospitalized patients often complain that they are unable to rest throughout their stay during an inpatient hospitalization due to unfamiliar noises, unfamiliar sounds, roommates, frequent interruptions from staff, and additional medical equipment and machinery. Patient satisfaction is measured through surveys that rate the quality of specific patient experiences within hospitals, and one of the categories is the volume of noise within the hospital on the unit in which they receive their care. And oftentimes patients require pharmacological interventions for sleep, such as sleeping medications, to ensure they will obtain adequate rest, which requires then providers to prescribe more controlled substances that they don't always feel are necessary, but due to patient complaints, they're likely to prescribe them to promote their sleep. According to Hedges, Hunt, and Ball, a study in 2018 showed that providing a restful environment in the acute care setting is challenging, but implementing designated quiet time hours for patients can both improve their quality of rest and improve their overall patient experience. Offering patients a sleep toolkit that contains an eye mask, earplugs, noise-canceling headphones, warm blankets, additional pillows, and dimming lights also showed to promote rest in another study that did offer quiet hours. And a third study completed by Applebaum, Callow, and Novell showed that 60% of surveyed patients felt that 1 hour of designated quiet time per day contributed to a quieter and more restful environment for the entire day. The purpose of this evidence-based practice project is to evaluate patient perceptions of noise in the acute care setting and determine the effectiveness of implementing daily quiet hours to improve the patient experience and patient satisfaction scores. The PICO question that is being answered is, in the adult medical surgical patients, does the implementation of daily designated quiet time hours compared to no designation of daily quiet time hours improve patient perceptions of noise? The population is adult medical surgical patients. The intervention is designated daily quiet time hours. The comparison is to no quiet time hours, and the outcome is to see if it improves patient perception of noise. For the literature search for this project, the databases that were used were CINAHL, PubMed, and Ovid. The inclusion criteria for the search included adults, inpatients, medical surgical, and noise reduction. Exclusion criteria was primarily pediatrics. As I searched for these articles, I did pick ones that had interesting titles and read the abstract to see if there was a summary of information that I was looking to obtain. And for the most part, I did come across level 3 studies, which were the 3 best articles I could come across to develop this idea. So I have listed here a literature synthesis table to go over each of the sources I used in this research. The study by Applebaum was called Implementation of Quiet Time for Noise Reduction on a Medical Surgical Unit. The study was completed in 2016, and it is a level 3 qualitative comparative design study. The patient population included 30 inpatient adults on a medical surgical unit in an acute care hospital in New Jersey. A strength of this study was that medical surgical patients were the population, but a weakness was that the sample size is small, with only 30 patients being included. The intervention of the study was to implement quiet time hours from Monday through Friday. And during that time frame, the nurses dimmed the lights, closed patient doors, and also created signs to introduce staff to quiet time that they would post on the outside of the doors, as well as educate all the staff about quiet time hours and to lower their voices at the nurses' station and further educate them on strategies they could use throughout the unit to promote patients' rest. The outcome of the intervention was that patients did report improved quality of sleep on an in-house questionnaire that they completed. They did speak with patients prior to implementing the quiet time hours, which was when they were admitted to the unit, and had them consent to give or to participate in the questionnaire. And then prior to discharge, after the quiet time hours were implemented, at least during 1 to 2 days of their stay, they had them rate their quality, the noise level quality on the unit after the implementation of the quiet time hours. And that did show an increase in patient satisfaction as well as decreased perception of noise. Another study was completed in 2019. It was a level 2 descriptive study of quality improvement design. It was called Quiet Time Improves the Patient Experience, and that was completed by Hedges, Hunt, and Ball. This patient population was a bit stronger. There were 50 patients from 2 medical surgical units in an acute care hospital in North Carolina. However, again, the sample size is small in general, and it would have been better if it could have been a bit larger. They measured the actual noise unit through a computer program, and then also offered patients a sleep toolkit during select hours throughout the day shift on their unit. The toolkit contained eye masks, earplugs, and warm blankets, and the patients were very receptive in being offered that. And it did show that as nurses led this quality improvement protocol and implemented quiet hours with the sleep toolkit, the patient perception of noise significantly decreased, and their overall ratings through Press-Ganey scores did improve. There's a third study by McGough and colleagues called Noise Reduction in Progressive Care Units. This was completed in 2018, and it was another level 3 study. It was a quasi-experimental pre- and post-interventional design. It included adult inpatients from 4 progressive care units within a community hospital. They implemented a quiet time bundle with specific hours of these activities to be completed, which included offering the patient comfort measures by dimming the lights, offering earplugs, offering them sleep masks, offering them noise blocking headphones, as well as educating their staff not to interrupt patients unless absolutely necessary during those hours. The patient perception of noise decreased, as well as the nurse's perception of noise. And they also measured the actual noise levels on those 4 units and found that the actual level of noise decreased by 3 decibels during the implementation of the quiet time hours. A strength of the study was that it did focus on the patient perception of noises, but a weakness was the noise level was measured in decibels, and it would require more funding and resources for actual measurement of noise levels. And the focus is looking at patient perceptions, whether or not the noise levels do change. A 4th study was completed in 2018. It was called What's All That Noise? Improving Hospital Soundscape. This was a level 2 descriptive study, so it wasn't as strong as the level 3 studies. It did examine 11 acute care health systems. It did not specify the specific units that were included in these studies, but the intervention was that staff lowered their voice while talking, silenced unnecessary alarms, and enforced quiet hours, of which the hospitals already had policies for. And 5 of these acute care health systems recommended the same consistent interventions and had the same outcome. And they found, while looking back at all these studies, that overall nursing staff needs to enforce quiet hours and lower alarm volumes when possible to improve the perception of noise. because without the enforcement of it, there were many interruptions and the patient perceptions didn't change. But the strength of the study was that 5 of these systems validated and demonstrated that enforcing quiet time hours and lowering the volume on alarms when necessary did show an improvement in what the patients perceived the actual noise level to be. A weakness of those studies was that the exact sample size was not stated. The units that the studies were completed on was also not stated. And lastly, my final article was completed in 2017 by Wilson and colleagues, called Improving the Patient's Experience with a Multimodal Quiet at Night Initiative. This was another level 3 study. It was a quasi-experimental pre and post design. The patient population included 2 medical surgical units from a 350-bed acute care hospital. The intervention included staff education, a special nighttime cart, staff rounding, and the formation of a noise committee. The outcome was that the Press-Ganey scores on both of these 2 medical surgical units showed great improvement, and they also achieved a decrease in the decibel level of noise that was actually the actual noise on the unit. The strength of the study was that it did use Press-Ganey scores, and they utilized pre-implementation scores from up to 5 years prior and compared them to the post-implementation scores, which showed a significant improvement. However, the weakness of this was that it was not considered a high-quality study, but overall the recommendations were consistent with the other 4 studies that utilizing quiet hours or a sleep toolkit does contribute to a decrease in the perception of noise among hospitalized patients. Data from the study completed by Applebaum, Kahlo, and Novell suggested quiet time hours are effective in decreasing patient perception of noise when compared to no implementation of quiet time hours. Their study also found that both patients and staff members reported decreased noise levels on the unit, which increased both patient and nursing staff satisfaction. McGough found that implementation of a quiet time bundle during designated rest hours demonstrated an improvement in patient perceptions of noise, as well as decreasing the nurses' stress levels throughout their entire shift. So based on the findings of the 5 studies, I do believe there should be a change in practice. If there's not already a policy for quiet time hours, the next step would be to speak with the Nursing Quality Improvement to develop a pilot policy on designating 1 to 2 hours of quiet time for inpatient nursing units in order to promote rest for patients and improve satisfaction scores for noise. Patients could also be offered a sleep toolkit containing an eye mask and earplugs, with staff offering additional blankets, pillows, dimming of the lights, and closing the door, if appropriate, to keep patients comfortable. Offering a sleep toolkit would require a look at the fiscal budget, because you would be giving disposable items to each patient that comes in. But overall, it appears to be cost effective, as we already offer eye masks and earplugs to other patients in the unit. In conclusion to this project, although all noises cannot be eliminated from the inpatient setting among hospitals, staff should aim to dim lights, close doors, and speak in lower volumes when applicable. Implementing designated quiet hours each day could promote rest among hospitalized patients, which may improve patient satisfaction scores on Press-Ganey surveys or other HCAHPS surveys. Offering patients sleep masks or earplugs may assist patients in perceiving less noise and thus allow them to relax and fall asleep more easily while in the hospital. Implementing quiet hours and offering a sleep toolkit to patients could improve both patient satisfaction and nursing satisfaction, which could create a less stressful environment and promote retention of nurses within particular nursing units. Thanks for listening to this presentation. Here's the list of references used to complete this project.